right, so today we are going to begin and hopefully finish sexual reproduction. There's a lot of ground to cover today, so we're going to go into female pathologies as well as male pathologies, and then we're going to also sprinkle in a little bit of STIs in there as well. So, do you not like the way I put that? Sorry. So let's get into it. Here's the overview of all the things we're going to talk about. Again, like I mentioned, we're going to cover some of the more common female pathologies and some of the more common male pathologies as well. So lots of ground to cover. So let's start with benign breast diseases. Benign breast diseases are something that you're going to see pretty frequently. A lot of women are going to experience something like this at some point in their life, but it's not a big deal. They're benign, right? They're not necessarily cancerous. And so there's a bunch of different types of conditions. You can get these palpable masses that you might get. You might see things like dimpling of the skin, right? Because there's going to be a lot of connective tissues. And if you start developing like a fibrotic cyst or something, sometimes they can latch on to some of the connective tissues, pull it in a little bit, and that's going to cause the skin to dimple somewhat. So if you see a little bit of skin dimpling, that could indicate that there might be some sort of like fibrocystic change taking place. You can also see sometimes different types of nipple discharge. They're not always indicative of an issue. Sometimes they can be, though. So if you see abnormal nipple discharge, you usually want to follow that up with, different types of tests to see what might be the underlying cause. But some of the most common ones are going to be fibrocystic changes. You can also see fibroadenomas. If it's infectious, you might see abscesses. You might see papillomas within the ducts of the mammary glands. The two major types are going to be proliferative versus non-proliferative. If it's proliferative, that means that you're seeing something that might have a higher risk of developing into cancer. So that's one concern. And then non-proliferative, you're just basically getting increase in the amount of cells, right? So you're not going to develop an increase in cancer risk with non-proliferative. Now, breast exams and mammographies, ultrasound and biopsy. So when it comes, there's some varying debates on whether or not we should just be like always biopsying something when we find it on a breast. I've had some professors of mine when I was in med school that are very much against doing that, because if you're subjecting a woman to getting biopsies on a fibrocystic change, it's not necessary. If it's fibrocystic change, that's super benign. You don't really need to do much. Sometimes the biopsy in itself can cause some more damage than good, because a lot of these things are not going to be necessarily cancerous. So there's debate on that. So I guess it's really at the discretion of the practitioner whether or not they want a biopsy. But mammography is going to be really commonly done, right? It's minimally invasive, even though, at least according to my mom, it's very uncomfortable and it hurts a lot because they're like basically squeezing the breast down so they can get an x-ray of it. So it's not exactly a very pleasant procedure. But out of all of them, it's going to be one of the least benign. Then you can also do ultrasound as well. So fibrocystic changes, this is effectively just lumpiness, right? So you're getting basically lumps growing in the breast. You could get pain with that as well. And again, this does not mean that the person has an increased risk of cancer. Quite the contrary. It's pretty common and it's pretty benign. Some women can even get this if they had maybe a little injury, like something hit their breast. Sometimes just the healing process can also cause fibrocystic changes to take place. So a woman with a history of maybe a little bit of trauma or something, you could see this happening. It's not the end of the world. It's not cancer, right? It's completely benign. So what are other causes? Hormones can cause this too. Hormonal changes. And then you can also get these cysts that fill up with fluid, right? So those are some of the causes. You want to rule out breast cancer. So, you can test to see if there's on the physical exam of the breast, you can check to see if there's mobility. of the actual mass. You could see if there's abnormal discharge, right? Consistency, and then changes over time. You could do like a follow-up visit on the patient, right? The patient could come to see you again later in the future to see if anything has changed with that mass. If you see some significant changes over a short period of time, it could potentially be cancerous. So you could also do mammography as well, right? Mammography and ultrasound. And so this is what you would see on a mammogram. That's a little bit of a fibrocystic change, right? It's nothing really too crazy there. But like I said, it happens to a lot of women. So fibrocystic breast or fibrocystic breast disease can affect 30 to 60% of women and at least 50% of women of childbearing age. So this is extremely common, okay? So breast masses can be extremely common. What's not very common is when you get a condition like galactorrhea. And this is particularly concerning with dudes, right? If a guy all of a sudden starts making breast milk, right? What's up with that? That's not supposed to be happening under normal circumstances. So these are the major causes of galactorrhea. One of the major ones is going to be a prolactinoma, so a pituitary tumor. You can get other things causing it too, like thyroid disorders. Certain medications can cause this as well. And the treatment is really going to depend on what the underlying cause is. So prolactinoma, it's a tumor, but it's a pretty benign tumor. You can get some pretty nasty effects. You can get nausea, vomiting, headache, right? Tunnel vision. Bilateral hemianopsia is going to be the major thing. So you're basically losing your peripheral field of vision, right? We talked about this already when we were discussing neuro and endocrinology, but just to bring this back up again, you lose peripheral vision. So if they start getting tunnel vision, where they're only really seeing like the central field of vision, and they have headache and all that, then you might want to suspect they have something going on with their pituitary gland. So you can test their prolactin levels. You can do an MRI or biopsy. For treatment, you can treat it with drugs. So bromocriptine is a dopamine agonist. So it works on the dopaminergic system. And when you have dopamine being released, it's going to help to reduce the amount of prolactin, and it's going to reduce the amount of discharge from the nipples. So that's one option. Or if it's pretty severe, you can also treat it with a hypophysectomy. So you can actually go in and remove the pituitary gland. But of course, for the rest of the person's life, they're going to have to go on hormone replacement therapy, right? Because there's a ton of different hormones that's released by the pituitary gland. You're going to have to go get hormone replacement therapy for thyroid, for cortisol, for everything that the pituitary is involved in. So it's not exactly an ideal procedure, but you can do that if it's severe enough. Mastitis, this is something that happens when a woman has a baby, right, and they're breastfeeding. So the most common cause is breastfeeding, and it's going to happen about 1 month after having the child. There are certain risk factors that can cause this. So if you have any sort of like nipple piercings, if you have any sort of damage to the nipples, like fissures, if the ducts get plugged up, they could start getting infected with bacteria. So when you get all this stuff happening, it's going to cause a lot of pain, swelling. You might get some discharge as well. So these are all the signs and symptoms: tenderness, swelling, erythema. You get burning sensations. Because it's infectious, you might also get fever and flu-like symptoms too. If it's really bad, you can also start seeing mass abscess formation happening. Now, what does that mean for the child that's breastfeeding? You don't want to stop breastfeeding the child. You want to continue breastfeeding. So one thing that's interesting about this is that it's still safe to continue breastfeeding the child even if the woman has mastitis. As a matter of fact, there's certain things that can really help to alleviate the symptoms of mastitis. You can actually use milk pumps, right, that help to remove the milk, and just that in and of itself can help to relieve some of the symptoms. Of course, you want to go on antibiotics, right? So those are some of the major considerations for mastitis. So you can still continue to provide milk to the child as they're breastfeeding. Now, breast cancer. There's a lot of risk factors that come into breast cancer. So a lot of times it could be idiopathic, right? We're idiots and we don't know exactly what's going on, or it could be genetic, right? And if you have a first-degree relative, that means a mom or like a sibling who has had breast cancer, that increases your risk of developing breast cancer tremendously. Now, one of the major genes that are involved are going to be the BRCA1 and BRCA2 genes. So BRCA1 and BRCA2 are some of the more significant genetic mutations that increase the risk of breast cancer, but not just breast cancer, also ovarian cancer as well. So individuals who test positive for BRCA and BRCA2, BRCA1 and BRCA2, there's different things that they can consider doing in terms of treatment. They can do a prophylactic type treatment where they actually like remove their breasts, right, just to prevent the risk of getting breast cancer. But of course, those are all things that they would have to consult with their primary care gynecologist and everyone that's involved in their medical care. So what are other things that might increase the risk? So age, as you get older, right? Radiation exposure, like if you're working in radiology, right? Just exposure to X-rays and things like that, that can increase your risk. Obesity. If a person goes into puberty too early menarche can also increase their risk of developing breast cancer. Late menopause. So notice the theme here, estrogen, right? So exposure to estrogen for a longer period of time can increase your risk of developing breast cancer. This is one of the reasons why going on hormone replacement therapy, if you're going through menopause, is not a great idea, because if you take HRT with estrogen, you're gonna reduce your hot flashes, you're gonna reduce your risk of getting osteoporosis, but on the contrary, you're gonna increase your risk of developing breast cancer, uterine cancer, ovarian cancer. So those are all things to take into consideration. So estrogen is good to a certain extent, right? If it's too much, that increases the risk of cancer. A person who never had a child, so individuals who are nulliparous, folks who are on hormone replacement therapy, we just talked about that, and those of us who are booze hounds, drinking alcohol can also increase the risk of cancer too. Signs and symptoms, this might be painless. You might get a lump, right? So that's one of the reasons why it's concerning if you have like a fibrocystic change, because fibrocystic change can also cause a lump too. So that's one of the major concerns. Palpable lymph nodes. So when part of physical exam, you want to feel underneath the person's armpit, right, in the axilla. So you want to try to touch to see if you feel any lymph nodes in there. And so if you feel lymph nodes, the axillary lymph nodes are the very first lymph nodes that you'll start seeing metastasis. If you have breast cancer, those are the first lymph nodes that get involved. And what else? Erythema, of course, nipple discharge. There's different types of nipple discharge. It could be like milky, it could be bloody, it could be just like fluid. So there's different types of discharge. Dimpling of the skin, nipple retraction. So this is an image right here that really helps to show what nipple retraction looks like. If the nipple all of a sudden gets pulled in, that's a really huge concern, especially if you combine that with peau d'orange, which is from French for this peel, the skin of the orange peel. And you'll get all these crazy little dimples done. This is because you're having lymphatic obstruction. If you have lymphatic obstruction from the cancer, you're going to start getting accumulation of fluids, and you're going to start seeing dimpling of that because there's fibrotic tissues inside the breast. Those are pulling the skin in, and so that's what causes all those dimples. So it looks like an orange when you have peau d'orange. There's a bunch of different types of carcinomas. You are not at all responsible for any of these, but if you go on to practice gynecology, obs and gyn, you would be familiar with all these, especially if you work in oncology too. So different types of cancers that could affect the breast. In terms of classification of these cancers, so we talked about your BRCA1, BRCA2. There's also your HER2 type of cancer. So this is the human epidural growth factor receptor 2. There's also estrogen receptor, there's progesterone receptor type of cancers. So there's different types of cancers. This flow chart here, HR, I should have put like in a little subheading. HR stands for hormone receptor. So if it's hormone receptor positive, it could be due to BRCA. It could be due to one of these, right? It could be like estrogen, it could be progesterone, it could be your HER2. So here's your HER2 positives versus HER2 negatives. There's different kinds of meds that you can take as well. So like tamoxifen would be like one example of a drug if the person, it turns out to be HER2 positive. So lots of different types of treatments you can do depending on what the underlying cause is of the individual's breast cancer. And by the way, if a guy gets gynecomastia, they get breasts, right? That increases a guy's chance of developing breast cancer as well. So guys with gynecomastia, that's one thing to watch out for. There's cases, it's not common, but there's cases of guys developing breast cancer, and that's increased if they have gynecomastia. So here's a review of all your hormones. So you got estrogen and FSH. Those are going to be super important, right? So FSH is really important to develop the follicles. You have your primordial follicle, primary, secondary, tertiary follicles. Those are the things that basically provide support for the developing oocytes, right? You got your primary oocyte, then you have your secondary oocyte. Secondary oocyte is what gets ejected during ovulation, right? And then it gets sent into the fallopian tubes to eventually make its way down to the uterus. And if there's sperm present, then you'll get fertilization and implantation into the endometrial lining. LH, luteinizing hormone, you get an LH spike right before ovulation. One thing that you can also see in some women, they call this Mittelschmerz pain. That comes from German for middle of the cycle. So at around day 12, day 13, day 14, right when ovulation happens, sometimes women, depending on which ovary is ovulating, they might feel pain in their either right lower or left lower quadrant. Why is that important? Because you might think that might be appendicitis if it's in the right lower quadrant, right? But if it's a woman who is in like a childbearing age, right, it could be Mittelschmerz pain, which is going to correspond with ovulation mid-cycle. So in other words, you don't really want to worry about that. You can give the person, some acetaminophen or something just to help like reduce the symptoms of the pain. Yes?
You're not going to get like tenderness with that on patient, right? Like with Mittelschmerz pain versus appendicitis.
Yeah, because with appendicitis, you get like rebound tenderness. Yeah, not so much. I mean, with appendicitis, you're going to get all sorts of stuff. You're going to get leukocytosis, fever, right? You're going to get all that stuff as well. Mittelschmerz pain, you get none of that. You just get the pain in the area, right? Either right lower or left lower quadrant. Good question. Luteal phase, that's where after the egg gets ejected, right, from the ovary, then all that follicle turns into the corpus luteum. And the corpus luteum comes from Latin for yellow body. And the yellow body, the corpus luteum, is what produces progesterone. And progesterone, think about it as progestation. It basically provides all the support necessary for gestation to take place. So like development of the baby in utero. And then the corpus luteum eventually turns into the corpus albicans if there's no implantation. The corpus albicans, again, comes from Latin for white body, and that's when the corpus luteum just basically degrades. And then if implantation doesn't take place, that's when you get menstruation. Okay, so menstruation comes into play. So now the functional zone of the uterus that built up during the proliferative phase, and then during the secretory phase, if you guys remember your AMP, then you have degradation of the functional zone. And that you have the spiral arteries that provide blood to those regions. The spiral arteries degrade, and then you have necrosis, basically, of that whole entire region. That's when you get menses, right? Then all those areas get sloughed off into the period. Now, perimenopause for women, that's when you're about to approach into actual menopause, and it can take place over a course of years. During this period, you're going to see spikes of FSH, spikes of LH. You're going to see estrogen going up as well. Then you have endometrial thickening. You can start seeing dysfunctional bleeds taking place. So we're going to talk about dysfunctional uterine bleeding later on. Then you also see reduction in progesterone, and you start seeing hot flashes. So hot flashes are going to be the hallmark of a woman who's about to go into menopause. So you get increased temperature, you get like vasodilation, peripheral vasodilation, so all those hot flash symptoms. Then you get the temperature might drop, and then you get like perspiration because of that. You get night sweats. It's just extremely uncomfortable, basically. So hot flashes are not fun. There are certain meds you can take. You can do hormone replacement therapy again. There's also certain like naturopathic meds you can do, like black cohosh, if I remember correctly, is a natural herb that you can take to help prevent this. But again, it can also potentially increase your risk of developing cancer too. So those are all things to keep in mind. So when you have menopause, that's when you have amenorrhea. Amenorrhea means you stopped menstruating altogether. And once you do that for over 12 months, that means that you are currently in menopause. Both estradiol and progesterone levels are going to tank. FSH and LH still remain elevated, but you're basically going to have no ovarian function. What happens to a woman when she goes into menopause? She gets breast atrophy. It starts to shrink a little bit. Also, the uterus is also going to atrophy. Ovaries atrophy. The vagina, the walls, the mucosal membranes of the vagina are also going to shrink and atrophy and become thinner over time. You also get dryness. You get less lubrication. So all this stuff happens. So it's very, it's unpleasant stuff. You also get bone density changes, right? Obviously with osteoporosis, osteopenia that turns into osteoporosis, that's one of the big concerns with like bone fractures. Other things that happen, you might also get increase in LDLs, your blood pressure might go up. You might start seeing skin in general is going to become more dry and weak. And emotionally speaking, you go into a lot of emotional distress when you're going through menopause. So it's not a fun situation. But it happens, it's a natural part of life. One of my students was asking me this morning in my A&P class if a person goes through a hysterectomy, if they go into menopause. The answer is yes and no. There's different types of hysterectomies where they remove a portion of the uterus, right? So there's ones that are that they salvage the ovaries. So if a person has like any sort of like fibroids or endometrial issues, they can get a hysterectomy to remove the the uterus, but they can save the ovaries so that can prevent menopause. But if you remove the ovaries and you do like a radical hysterectomy, which you can do for a patient with like BRCA 1 or 2, sometimes you might want to do a radical hysterectomy, then you're immediately throwing the person into menopause. And then that sucks, right? You might want to go into estrogen or hormone replacement therapy for that, but it's not an ideal situation. But it happens. Here's some terminology that you guys need to be familiar with. So we already talked about amenorrhea. That's where you stop the bleed, right? You're no longer producing menses. There's dysmenorrhea. Dysmenorrhea means you have painful menses. This is extremely common. The stats that I read, it's like anywhere up to like 50% of women experience some form of dysmenorrhea, at least 1 or 2 days of the cycle. And it's common, right? You take drugs like acetaminophen, right? Those drugs to reduce inflammation and pain that can help. Menorrhagia. Menorrhagia means that you're bleeding way too much. So the menses is very heavy and very long. You know how women tend to be a little bit more anemic than men, especially in reproductive age? This is one of the reasons, right? It's during menses. So a woman's hematocrit is always going to be a little bit lower than a man's hematocrit, right? It's going to be like roughly like 40 or so. For a guy, on average, it's about 45. So women are always going to have a little bit less red blood cells than men. It's because of the menstrual cycle. And so you can get anemia from this. If it's extreme, like if you're bleeding a lot, you can get anemia. Metrorrhagia means irregular periods. Irregular intervals. So you're going to have sometimes bleeding happening mid-cycle. Then menometrorrhagia means that you have both menorrhagia and metrorrhagia. So you're going to have both heavy periods that are going to be irregularly spaced out. Oligomenorrhea is infrequent. You get less than 8 per year, right? So that is oligomenorrhea. Remember we talked about oliguria, that's like where you have reduction in urine. So this is kind of a similar concept, oligomenorrhea, it's less than normal. Or polymenorrhea, which means that you're having way too many menstrual cycles, over 16 periods a year. So, dysmenorrhea. There's a couple different types. You got primary dysmenorrhea. So you have painful menstrual cycle in the absence of pelvic disease. This is like severe uterine cramping. What's going on here? You got prostaglandins and leukotrienes coming into play. Prostaglandins are going to cause myometrial stimulation. So you get these like contractions, right? Prostaglandins are going to effectively allow for contractions of the uterus. And so you get all these contractions that might impede on blood flow. And then that just causes pain in and of itself. So that's one thing. And then leukotrienes are other pain mediators, so you get pain from that as well. Then there's secondary dysmenorrhea, and this one's scarier. It can involve endometriosis, which we're going to talk to in more detail. That means you're having like little glandular hormonal secreting portions that should be within the uterus outside of the uterus. So that's what endometriosis is. And endometriosis can affect like almost any organ inside the peritoneum. It can infect the GI, it can affect the bowels, it can affect even the ovaries itself. So horrible, horrible situation. And then the other one is pelvic inflammatory disease, which is secondary to what? Do you guys know what PID comes from? I talked about peppering in some things at the start of this class, remember? So STIs, right? So gonorrhea and chlamydia are the two major causes for pelvic inflammatory disease, and we're going to talk about those in more detail. But that would also cause secondary dysmenorrhea. Now, amenorrhea, again, that's where you're not menstruating, so you have no menstrual period. Primary amenorrhea, this would be where you don't have menarche by 15 years of age. There could be different things that cause this. It could be like certain hormonal imbalances where an individual might not go into puberty when they otherwise should have. You can also see secondary amenorrhea. And this is for an individual who previously used to have periods, but for whatever reason they no longer do, or something happened where it stopped. Now, this could be due to pregnancy, right? If a person's pregnant, they're going to stop their period. So that's one of the things that you watch out for if you're trying to conceive a child. Once you stop your period, then you might be pregnant. And you want to wait maybe like a week and a half or so until you actually do a pregnancy test, because beta HCG doesn't really increase in concentration until a little bit along the way in terms of pregnancy. It usually takes like 4 weeks or so for it to be detected after conception. And think about when conception happens. During ovulation, the egg is only viable for about 12 to 24 hours. If there's no sperm present, then the egg basically dies and it disintegrates, and then it gets released during menstruation. But during fertilization, it has to be within that narrow window of time, around like day 12, day 13, or day 14, right, of the cycle. That would be like when fertilization took place, mid-cycle. And then beta HCG only really becomes detectable about 3 to 4 weeks after actual conception takes place. And so you'd have to wait a little bit for that. But other things can cause secondary amenorrhea, not just pregnancy. Weight loss. If a person's losing a lot of weight, that can happen. Malnutrition, excessive exercise. Are there any ballerinas in this room? There's no ballerinas in this room. My mom was a ballerina. Uh, her ballerina instructor was like this. I'm not going to say anything disparaging, but he would say that if his students were having their periods, they weren't practicing enough. Yeah, that's horrible, right? So if you are exercising a lot, that stress is going to affect the ability for you to menstruate as a woman. Weight loss. Why weight loss? What are the precursors for your hormones? What do you need to make a hormone? A lot of your hormones. You need lipids, right? You need cholesterol. Cholesterol is important for the ability to synthesize hormones. So if you don't have enough cholesterol in your body, you're going to start seeing hormone imbalances. And so that can cause amenorrhea as well for women. Hypothyroidism, PCOS, which is polycystic ovaries. We'll talk about that in more detail a little bit later on. And then hyperprolactinemia. This over here, this is all Tanner staging. They call this Tanner. I'm going to put that in there. So staging that specifically refers to Tanner stage. So when you're doing like a physical exam on a young woman or boy, but for this, we're focusing on women here, but you can do Tanner staging. So you can, track the development of a young individual. So when they're really young, Tanner stage 1, right, they don't really have any breast development. Then Tanner stage 2, you start seeing like, what would you call it? I forget the term for that, but you start like seeing a little bit of breast development, just a little bit. And then you follow along until you get to Tanner stage 5. Tanner stage 5 is going to be like a fully matured, developed individual, right? For this, Tanner stage 5 would be a fully developed woman, right? You can also see the distribution of body hair as well. So distribution of pubic hair can also help you with Tanner staging as well. Yes?
Like, I don't know, certain are the age ranges? Like,
it varies.
Like a lot.
It varies a little bit. I mean, so
Like, what would you say, like, 5 is age?
11 to 12 years of age is when a woman usually undergoes puberty, right? Some women have puberty later. Some women get puberty earlier. And here's something that we were talking about in my A&P class this morning. I just for fun, because I've heard stories about women going into puberty very early and also getting pregnant at a very, very young age. And so the record is this lady, she was 5 years and 7 months of age when she delivered her child. So this is the youngest person in recorded history to have developed a child. Her name was Lena Medina. So Lena Medina, she was Spanish. She was from Peru. She was Peruvian. Youngest woman to ever give birth. 6 years old. Talk about age of consent, right? Like what the hell was going on there? Horrifying stuff. So she was the youngest person to ever deliver a child. So some people can go into puberty at a very young age. And actually, it's kind of interesting, too. There's been a lot of research as to individual, like women who are raised in a single mother household. There's no dad around. Those women, on average, tend to go into menarche at an earlier age. Why is that? The theory is that if there's no father or male figure in the household, through like evolutionary biological processes, the young girl is going to try to find a father figure through like a mate, right? So they're going to undergo puberty at an earlier age. That's one of the theories behind that. But women who have a father in the household generally go into puberty a little bit later. But that's on average, right? So it really just varies from person to person. What's up? No, I haven't seen any studies about that. Yeah, that would be interesting to look into, though. I would imagine it would be the same thing. It would probably go into puberty earlier. Yeah. The other thing that I looked up, which is also kind of interesting, is we talked about menopause, right? The ages vary. It's anywhere between 45 to 55 years of age is when a woman goes into menopause. The oldest recorded woman to ever have a child was in this year, 2023. Xinju Qian, I guess she's from Asia. 67 years old. It's the oldest recorded woman to conceive naturally. There's an older woman than that. She's like in her 70s who conceived a child, but through IVF, in vitro fertilization. So it's a little bit different. But this one's through like natural means. 67 years of age. I thought, huh? I didn't look into it in that much detail, but I assume she did. I don't know. The first child that I mentioned, the 6-year-old girl, she had to have a cesarean section because she was so tiny, she couldn't like deliver the child naturally. Anyways, so wild, right? Biology, there's always exceptions to the rule, right? So there's always going to be those like fringe cases at the ends of the bell curves. I'm not going to go into all this stuff. These are all the different things that can cause changes in your menstrual cycles, but you can review that on your own time. Dysfunctional uterine bleeding. Now, that's where you have abnormal bleeding. It's not necessarily associated with cancer, inflammation, or pregnancy. So you have irregular menstrual cycles, and that's usually going to be due to hormonal imbalances. So we already talked about all these different terms. We talked about menorrhagia, right? Heavily bleeding, metrorrhagia, irregular intervals, etc. So that is dysfunctional uterine bleeding, or DUB. Now let's talk about ovarian cysts. So ovarian cysts, they're usually going to be unilateral on one side. You don't always notice them. Sometimes they can be asymptomatic. But if you do get symptoms, you might get a little bit of pain, you might get some bloating. Dyspareunia is where you have pain with intercourse. Okay, so that can happen if you have polycystic ovary disease, right? You'll get like dyspareunia. You can also see your menses being affected. And why do you get this? Hormones. Again, you get hormonal imbalance. And so some follicles are not going to get properly stimulated during development. And so you might not get any follicle reaching maturity. So you're not going to get any sort of release of your secondary oocyte during ovulation. Ovarian cysts can potentially rupture, so you can get hemorrhaging. So that's something you might see. You can diagnose this easily with an ultrasound. You can see the cysts on ultrasound. But you also want to rule out cancer. So you want to check CA-125 is one of the biomarkers that's associated with ovarian cancer. So if a person has ovarian cysts, you want to watch out. It could be cancer. So you do this test, CA-125, to see what's going on. If it's just ovarian cysts, then you can give them contraceptives. Okay, so you can give them oral contraceptive pills. It can usually resolve on its own. If they're postmenopausal, you could also remove the organs. Thank you for doing that. What's up?
With the CA-125 and like the BRCA thing you were talking about earlier, is that something like if you were tested for that, like in your teens or early 20s and you were negative, are you good for the rest of your life?
Not necessarily.
You want to get tested?
For BRCA, yes. If you test negative for BRCA, then you're fine for the rest of your life. But cancers can happen at any point in anybody's life, right? So yes, if they are BRCA negative, that's good. That means that they're reduced risk of developing cancer. But at some point in their life, they could potentially get cancer. Right? So it could happen at any time. What's up?
Is that something that they just test for, like BRCA1, 2, or
If you have a family history. If you have a history of cancer in your family, you're going to want to, especially if it's BRCA positive cancer, you're going to want to get that checked. Yeah, it's a good idea to go into genetic counseling and to see if you have the risk factor. So anytime a person has a first degree relative, right? So parent or a sibling, that's a huge concern when it comes to things like cancer. Ovarian cancer. So this is, usually people don't notice it when they have it. So a woman doesn't notice it, so it's a silent killer. Lots of people get this annually worldwide. Lots of people die from it. So it's a pretty significant thing that happens to a lot of people. Again, risk factors. Excessive exposure to estrogen. So if you go into puberty at a very early age, right? We call that precocious puberty. Precocious means you're a very young person and you're going into puberty young. So this can happen to both guys and gals, right? Guys can also go into precocious puberty too. But for women specifically, you're going to get more estrogen exposure if you have early puberty and late menopause. If you never had a child before, that's nulliparity. Nulliparity is a person that's never had a child. They also have increased risk of ovarian cancer. And then again, those genetic mutations like BRCA1 and BRCA2, that increases your risk of ovarian cancer tremendously. The symptoms might be vague. You might feel like a little bit of discomfort in the abdomen. Appetite might be affected. You might get some pain. Dyspareunia, right? Again, pain on intercourse. That's always a concern. You want to work up a patient if they have dyspareunia, right? It's not normal for a person to have pain during intercourse. So that's one thing to keep an eye out for. Ultrasound, biopsy, and you can again check that biomarker, CA125. If it's CA125, very high chance that that is cancer. So we talked about ovarian cysts. Now, polycystic ovarian syndrome is PCOS, also known as Stein-Leventhal syndrome, but we're not going to refer to that in this class. It's going to be PCOS. These are the major things that you would see. Reduction in blood during menses, so oligomenorrhea, or amenorrhea, if you stop bleeding altogether. Also, hyperandrogenism, so androgens. I'm talking mustaches, I'm talking like sideburns, beards, right? If you start seeing hair growth in places that it doesn't belong, that's hyperandrogenism. And then if you look on the ultrasound and you see something like that, those are a bunch of little tiny cysts within the ovary. So that's polycystic ovarian syndrome. So what's going on with PCOS? You got FSH and LH are going to be basically affected. They're off balance. You get infertility because you're not producing viable eggs. You get irregular menses, or it's completely absent. Estrogen levels might be increased as well. And so you can get issues like hyperplasia of the endometrium. And then this is the big thing, virilization because of androgens, right? If you have too many androgens, you get too much testosterone, you start developing hirsutism, right? So hirsutism, hair where it doesn't belong. You can also start seeing acne, alopecia, right? So a woman might start losing their hair if they have PCOS, so they can get alopecia. Hyperinsulinemia. You develop insulin resistance with PCOS. So with that, you would see things like all the hallmarks of diabetes, right? As well as acanthosis nigricans. Remember acanthosis nigricans when you talked about diabetes? Those are those dark, velvety skin patches that would be found on like the folds, right? The back of the neck. It can also be on like the axillary folds, those areas. You might see dark, velvety skin. And then other things too. You could see hyperlipidemia, coronary artery disease, hypertension, fatty liver disease, etc. You can treat these patients with spironolactone. Spironolactone, which is a diuretic, can also help to reduce the symptoms of PCOS, and it can also help to reduce those androgen type effects as well. Yes?
I was just going to ask, because Cushing's disease also has hirsutism and amenorrhea. Are those two related, or are they totally different?
They're completely different, right? Because with Cushing's disease, that's pituitary, right? So it's a pituitary adenoma. So it's going to have a lot of those similar symptoms, but it's not. So it's a different cause. That would be a good like differential diagnosis. It's similar where you might want to consider doing a workup for it. So that's a good question. It is kind of it does look a lot alike, but they're unrelated. It's just a different process. So here's your hirsutism, right? You got lots of hair where it doesn't belong. This is very common. Lots of women have PCOS. My first girlfriend had PCOS. She was freaking out too when she got diagnosed. She thought that she had cancer, but it wasn't. It was just PCOS. Nothing too crazy. PCOS diagnosis: estrogen levels, testosterone levels, LH, and reduced FSH. So everything else is high. FSH is going to be low. They could be bilateral. So you look ultrasound at both ovaries. If you see something like that, that's polycystic ovarian syndrome. There isn't a cure for it, but you can take meds to help alleviate symptoms. So if you have like all the glucose issues, the diabetic type symptoms, then you could take metformin. You could also take oral contraceptive pills, so that can help with regulation of the hormones. Aldolactone is similar to spironolactone. Spironolactone, especially, that's a potassium-sparing diuretic, and that can also help to alleviate some of these symptoms. And if a person has lots of hair in their body, they're going to have to go into electrolysis. And unfortunately, insurance doesn't pay for it, so you have to do that out of pocket. So, bummer. Any questions on PCOS? Cool. So let's talk about leiomyomas. This is commonly referred to as fibroids. So if somebody says, oh, I had uterine fibroids, this is what they're referring to. It's leiomyoma. These are benign, and they involve the smooth muscles, and it's going to be a tumor. So it's a benign tumor of the smooth muscles. Lots of women get these. Very common. And as a matter of fact, this is one of the major reasons why some people get hysterectomies is because of this, leiomyomas or uterine fibroids. Usually happens in a woman's 40s. There could be genetic reasons for it. It could be hormonal. Again, though, a lot of us are idiots and we don't know exactly what the cause is, so it's idiopathic. Usually you don't really see any symptoms, but you could see all the other stuff too. Like you could see menorrhagia, you could see dysmenorrhea or metrorrhagia, pain, right? A lot of pressure, especially depending on what kind of fibroid and how big it is, right? So fibroids could get pretty dang big. Like look at the size of this one. So this is the uterus right here. That is the fibroid. So that's really, really, really huge. So you can get some pretty big fibroids. So they can vary in degrees of severity. Signs and symptoms, you could see GI getting affected. So you can see constipation, cramps, all that stuff. How do you diagnose it? You could do a pelvic exam on the patient, so you can palpate it. Right? You can palpate like a uterine mass. You can also do an ultrasound, so you do a transvaginal ultrasound. You could do a biopsy if you're thinking that this could be potentially cancer. And you can also look at their hormone levels. Now, how do you treat it? You could do birth control. After menopause, these can tend to go away, but if it's really, really, really bad, hysterectomy sometimes is indicated to treat these patients. Like, look at this uterus. That's a lot of fibroids, so pretty severe. If it's that severe, usually hysterectomy is the option. If it's a young woman who still wants to have children, then you want to try to avoid doing a hysterectomy, right? You want to see if there's other alternatives that you can use to be able to treat that, right? But if a woman doesn't care, doesn't want any more kids, maybe had enough, she's already got enough to deal with as it is, you can consider doing a hysterectomy.
Does it affect pregnancy or childbirth at all?
It could, yeah. So a woman with fibroids, it could affect the pregnancy. Absolutely. It could affect her fertility, right? Because even think about these things over here. Like you got the menorrhagia, dysmenorrhea, metrorrhagia, all that stuff. So like the menstrual cycle can be affected. If the menstrual cycle is affected in the person, that could also affect their fertility too. So yeah, especially if it's like really severe, you know, that could definitely affect the ability for a child to develop in the womb. What's this? That's an IUD, right? So that's a intrauterine device, which is one of the most effective methods of birth control. Right? Intrauterine devices are way more effective than combined oral contraceptives. There's different types of IUDs. There's ones that contain hormones in them, but there's also the all-natural ones that are made of copper. So copper IUD is a really good option as well. Copper tends to kill sperm. So that's kind of one of the mechanisms of it. And then the IUD in and of itself generally inhibits the ability for the embryo to embed into the endometrial lining. But not always. There's exceptions to that rule as well. There are lots of cool pictures that you can find online. If you look at medical talks, even on medical talks, they have like some images of like a kid with an IUD, like born stuck with an IUD like on their head. There's another really funny one that's like a little kid like grasping, like holding the IUD. so there's been cases of pregnancies, even despite having an IUD in there. Does an IUD affect fibroids? I looked all over the internet, and there's varying degree. Different studies say different things. This was the one that I thought was like the most legitimate one. So in participants who had fibroids, IUD use was found to be statistically significantly higher. But look at that. The numbers are really not that big, right? 55% compared to 43%. I don't know. There's other websites and other studies that kind of debunk that, but I don't know. So IUDs are pretty benign for the most part. They only last about 10 years, so if you have an IUD after 10 years or so, you might want to get it replaced. But adenomyosis. So whenever you hear adeno, like adenocarcinoma, this is involving glands, right? So adenomyosis is also involving glands. So it's a glandular endometrial tissue. It starts invading the myometrium. For the most part, this is going to be benign. And the risk factors, 30 to 50, if you're obese, you've had a lot of children, so multi-parous, menarche, early menarche, right? History of uterine surgery, those are all the things. What are the things that you might see? You might see all those other symptoms like dysmenorrhea, menorrhagia, etc. You might also see enlargement of the uterus. So you can palpate that on a pelvic exam with a female patient. And pain on palpation, you might see that as well. You could do a CT. You might want to do a biopsy to rule out cancer, like more significant cancer. And you want to do contraceptive drugs. So oral contraceptive pills would be a decent approach in treating adenomyosis. Now the next one is endometriosis. So this one's really nasty. I've known people that have had endometriosis, and it's extremely painful and extremely debilitating, and it can affect not just the reproductive organs, but it can affect organs beyond that, like the GI organs. I'm talking bowels, right? So not a great thing. This is where you have growth of endometrial tissue outside of the uterus. It makes its way outside, and it can affect anything from like the ovaries, the fallopian tube. Again, it can affect the bowels. So not great. Causes, it's unknown. It could be hormonal, fetal development, family history, Caucasians, Asians. So this just randomly happens, basically. What you start seeing with signs and symptoms, you get really bad pelvic pain. Another thing you might see is infertility, right? Especially if it affects the fallopian tubes, dysmenorrhea, menorrhagia, dyspranuria. Dyschezia. Dyschezia means a difficult time defecating. So you have a hard time using the restroom. That's because endometriosis can affect the colon, right? It could affect the rectum. It could affect all of that. Another huge concern is adhesions. So if you have adhesions, that's where you have portions of things in the peritoneum just like binding to each other. The inflammation and the healing process can start making like fibrotic type adhesions where you have bowels coming into contact with each other when you shouldn't, so that could cause issues like constipation, bowel obstruction, etc. How do you test for this? Physical exam, laparoscopic surgery. So you go in there, right, do 3 little incisions, and you do like exploratory laparoscopy. So you can explore the GI to see if you find, or the peritoneum to see if you find any signs of endometriosis. It could be DUB or pelvic pain as well. Now, this is what you see on laparoscopic surgery. You go in with a camera, you fill it up. You fill up the peritoneum with you get a gas-filled peritoneum, so you can really visualize everything that's going on in there. And you do a little exploration, and you see if you can find any sort of signs of endometriosis. So here's an example of endometriosis. You got adhesions over here. That's where you're having like things like either bowel connecting to bowel or even bowel connecting to the reproductive organs. So those are all things you might see on laparoscopic surgery. So here's a good comparison of adenomyosis compared to endometriosis. Again, adenomyosis, that's where you have those secretory glands. penetrating into the muscles of the uterus versus endometriosis. It's where you have those secretory type glands, but they're in different parts of they're outside of the uterus, effectively. It's either on the reproductive organs or on the bowels. All right, we're in the spicy side of this lecture, so this is where we're peppering in some STDs, okay? So STDs, genital urinary tract infections, sexually transmitted disease, how do you prevent them? Safe sex practices. I'm going to show you guys some awesome posters that I absolutely love, because back in World War II, as it turns out, World War II soldiers were a huge fan of prostitution. And so guess what happened with these World War II soldiers? They would often get syphilis, they would get gonorrhea. And so a lot of these public health, public safety announcements, things like that. They had lots of these cool posters that they made back in World War II to help prevent people from doing naughty things. And so I like this one the most because a lot of these posters tend to be a little misogynistic a little bit. They're like, oh, she looks clean, but she's not. But so this is the one that I like the most for the guys. It's like, syphilis. All these men have it. That's a great poster. It's so funny. Women, stay away from dance halls. STIs such as chlamydia, trachomatis, and Neisseria gonorrhoeae. Those are some of the most common bacterial infections. They're mostly going to be asymptomatic, right? Asymptomatic, 75% of women asymptomatic for chlamydia. 50% of men asymptomatic. So easy to spread, right? Because you don't know you have it, you're going to spread it to people and whatnot. So here's some of the more like misogynistic ones, like booby trap. I just now realize the play on words here. Syphilis and gonorrhea. Gonorrhea was like the main concern back in those days, but it's not even the most common bacterial infection. Chlamydia is. Chlamydia is the most common. So they weren't really like super on top of their game when it came to like their microbiology. Some other really fun military posters. She may be a bag of trouble, syphilis and gonorrhea. Men who know say no to prostitutes. Spreaders of syphilis and gonorrhea. These are all these posters I found on motherjones.com, so you can like go to their website. They had some other ones too that were kind of fun. She may look clean, but anyways, pickups, good time girls, prostitutes, spread syphilis and gonorrhea. You can't beat the Axis if you get VD. The Axis powers. That's so funny. Huh?
Why would she agree to be on the syphilis poster?
Well, these aren't photographs. These are all paintings. That's a great question. Why would she? Yeah. Hey, so do you want a model for this poster that we're making? Yeah, you're gonna be a prostitute that has VD. Yeah, that's a good question. Yeah, these are all artistic depictions of people right there. Loaded. Don't take chances with pickups. Loose women may also be loaded with disease. Misogynistic, man. It's not just the gals. It takes two to tango. Happiness ahead for the healthy, but not for the diseased. Get full medical examination for VD before marriage. Wow, how romantic. Oh, God, I love those posters. They're so funny. All right, anyways. I hope you're not leaving because you're upset. Okay, take care. Anyways, candidiasis. So this is your yeast infection, right? So candidiasis, Candida albicans. Yeah, so you got basically yeast overgrowth. What causes this? It could be pH imbalance, right? So this is one of the reasons why you don't want to go douching. It's unadvised to douche because you can throw the pH off and that can cause dysbiosis. So what's happening here? You're going to get other risk factors. If you're wearing, if you go swimming, it's a good idea to change out of your swimsuit after you're swimming because extra moisture can also cause a excessively moist environment, which can cause yeast infections. Certain hormones can also predispose an individual to yeast infections. Antibiotics. it's kind of similar to the dysbiosis you get for GI. If you take antibiotics and like you wipe out your good bacteria, you get C. diff. This is kind of the same idea. You're wiping out the good bacteria in the vaginal mucosa. There's lots of bacteria in there, including lactobacillus. And remember, we talked about dysbiosis. If you take probiotics, lactobacillus is one of the major components of that. You also find lots of lactobacillus within the vaginal canal. Other things that can affect dysbiosis, HIV, AIDS, right? This is actually, if you have really severe candida, that's one of the AIDS-defining illnesses. And it can become systemic. It can affect the rest of the body. Usually it's asymptomatic. It can cause a little bit of redness. That's what the pruritus is. It can cause, of course, the discharge, very commonly referred to as cottage cheese-like discharge. It can result in pain on intercourse, so dyspareunia, as well as pain on urination, which is dysuria. When you diagnose it, you can do a potassium hydroxide prep, and then if you see this under a microscope, that would be an indication of candidiasis. How do you treat it? Very easy. There's different drugs you can take that are antifungal drugs. I knew someone in my life who would get these periodically, and she would use garlic. So take a sewing needle, thread it through a clove of garlic, and you have a string attached so it doesn't get lost in there. So you like put it in there, and that can actually help. At least it helped for the person I knew. And the studies on that, not such great in terms of like actual scientific evidence for it, but anecdotal evidence certainly exists. So that's one thing. So if you don't mind putting garlic up there, that can be one thing that can potentially help. Otherwise, there's meds for it that you can take that are, if not equally effective, probably more effective than using garlic. All right, syphilis. Syphilis, also a severe bacterial infection. It's going to be due to a spirochete, so Treponema pallidum is syphilis. And syphilis, I think, is one of the coolest ones of them all because it really had a huge impact on Europe during like the 1600s, 1700s, 1800s. When Europeans started colonizing the Americas, they brought with them smallpox, and they gave smallpox to all the Native Americans. But in return, the Native Americans, because in the U.S., the North America, Central America, South America, syphilis was endemic to the Americas. And so then syphilis was brought back to Europe in exchange. And so syphilis became a really big thing, big concern, not just for poor people, but also for aristocrats, right? Syphilis affected everybody, from poor to the very rich. And think about like the prudishness of Victorian England. You think about Victorian England, like everyone's kind of like stuck up a little bit, right? They're also very like prudish. A lot of that has to do with the fact that like sex was destroying their culture, their civilization, right? Prostitution, syphilis was like wreaking havoc on people from all demographics. So it was pretty wild stuff. You can see how that affected just the overall culture of Victorian England, for example. What does syphilis do when you get it? The very first thing you get, this is primary syphilis, you get a painless canker. So you get a sore, but it doesn't hurt. You're like, oh, okay, so whatever. You might get a little bit of lymphadenopathy as well. And then eventually the canker goes away. And you're like, oh, cool, I'm good. Yeah. But no, you still have syphilis. And so you can eventually develop secondary syphilis. And so after the sore appears, you can start getting dissemination to different parts of the body. So this can actually start affecting the palms of your hands, the soles of your feet. So you can start seeing these rashes. You can also start seeing warts, so condylomas can start showing up. You can also go into a period of latency, and the bacteria can start affecting different parts of your body until it develops into tertiary syphilis. And that's when you start getting other areas that are more vital, like the central nervous system starts getting affected. Some of the most famous authors, you guys like Friedrich Nietzsche, German philosopher, existential philosopher. Friedrich Nietzsche, this is how he eventually developed dementia. He started getting severe dementia due to syphilis. Ludwig von Beethoven, also, he was a big fan of prostitution, developed dementia and infected different parts of his Some people say that it was even like what affected his ears when he went deaf, because there was a couple different stories. Like his dad would also swat him in the ears if he like played a wrong note. But Beethoven also had syphilis, and it might have caused neurosyphilis, and it might have affected his cochlear nerve. So lots of famous people had syphilis. Even Adolf Hitler had syphilis. So lots of people had syphilis. Maybe that's what made Adolf so freaking insane. So who knows? So this is tertiary syphilis when it starts affecting the heart and the central nervous system. You can also start getting these gumma formations. It's granulomas. Tabes dorsalis, you start getting problems with the posterior column. So you might start getting like sensory issues, right? Because posterior column, dorsal column of your spinal cord, that relays from the spinal thalamic tract sensory input. So vibration, proprioception, light touch, things like that can also get affected. Tests that you could do the rapid plasma reagin test, RPR, or you could do the VDRL, the Venereal Disease Research Laboratory Test, and you can confirm it with FDA ABS. So these are the things you might see. So here's your painless canker, right? So that's going to be seen within the labia of this person. You can also see alopecia. You can see the palms and the soles being affected, right? Those are the rashes you get. Condylaroma, those are going to be like wart-like lesions being formed. This is just total side note. Again, remember how I said that this affected a lot of like Victorian England and all those like cultures in Europe. Powdered wigs kind of were a thing a lot because people were losing hair, right? Aristocrats that got syphilis started to like lose their hair, so they started to wear these powdered wigs. They would try to like cover up the lesions on their face with makeup. You can look online of some of the most horrendous things you could possibly imagine in terms of like facial growths and deformities from severe syphilis. So syphilis is a really nasty infection. So thank God for penicillin, because penicillin G, if you have syphilis, if it's primary syphilis, 1 shot of penicillin G. If it's secondary and beyond, 3 shots. Again, gluteal, right? Intramuscular shot in the gluteal region. Moving on from syphilis, condyloma acuminata, that is your genital wart. That is usually going to be associated with human papilloma virus. HPV is the most common sexually transmitted disease. It surpasses all of the other sexually transmitted diseases. And there's different serotypes of HPV, multiple different serotypes. The majority of them are pretty benign, and the worst that they usually do is they cause warts. The ones that are concerning are like 16 and 18. Those are the serotypes that cause cancer. So cervical cancer, penile cancer, anal cancer, throat cancer. Okay? All those areas can be affected by HPV, these serotypes that cause cancer. The common ones are 16 and 18, but there's other ones too. There's like 9 different variations. And if you take the Gardasil vaccine when you're younger, it's not really recommended for an individual who's like above the age of 26. But if a younger individual takes Gardasil, the Gardasil vaccine helps to prevent the ones that cause cancer. So that's a really good vaccine to take when you're a kid. Why is it that it's not recommended to take it as an adult? By the time you're 26, you've probably been exposed to it already. So Gardasil is kind of an ineffective option for older individuals in their mid-20s. So pretty debilitating stuff. You can treat warts with drugs like, what's it called? Oh my God, I can't remember what it's called. It's like a little ointment. It's derived from pine trees. Can't remember what it's called. Anyways, you put the ointment on. It's like 3 times a day, 3 days, and then it eventually falls off. I can't believe I forgot what it's called. Anyways, chlamydia. Again, chlamydia is the most common of all of these bacterial STIs, right? HPV is a virus, right? That's the most common STD. Chlamydia is the most common bacterial STD. Again, it's generally going to be asymptomatic. 75% of women asymptomatic, 50% of men symptomatic. If it does show symptoms, you can get cervix involvement. So cervicitis, the urethra could get affected. If the Salpinges get affected, that can also cause some symptoms, endometriosis, and then PID, pelvic inflammatory disease. That is the most concerning one of them all. You can treat this easily, right? You can use drugs like doxycycline, azithromycin, right, a Z-Pak. Right? Those drugs are going to be pretty effective against chlamydia. But the biggest concern is if the chlamydia does not get treated, the biggest concern is infertility from pelvic inflammatory disease. Pelvic inflammatory disease, one of the major causes of infertility when it comes to these STIs. If a mom has chlamydia or gonorrhea and she delivers a child through the birth canal, normal labor and delivery, the child could get chlamydia in their eyes. And that's called neonatal ophthalmia neonatorum. And back in the day, they used to do little silver nitrate drops into the eyes of children that were born to prevent conjunctivitis for these kids. Nowadays, you just give them I think it's like Bactrim is one of the, gentamicin, I think. It's gentamicin drops now that they use. So if a guy gets this, chlamydia, he could get epididymitis. And so epididymitis, if bad enough, could also cause infertility for men too. So epididymitis, the epididymis is a tubular structure that sits on top of the testes and it curves down to the side and then eventually turns into a vas deferens. All right, the epididymis is where sperm is stored and undergoes maturation. So if you get epididymitis, that can cause some serious issues. It can cause infertility for men. So chlamydia and gonorrhea are going to be the most common causes. Other bacteria can cause that too, but it's usually chlamydia and gonorrhea. How do you check for this? It could be warm to the touch, right, because of the infection. But the other thing you could do is the positive friend sign. So you put on a glove, right, because you don't want to touch your patient with your bare hands. You put on a glove and you lift their testes. If you lift their testes and that alleviates the pain, that's a positive friends sign. Not friend sign, positive friends sign. And so why is that? Because you have gravity is pulling on all these structures. As soon as you lift it up, that alleviates the pain a little bit. So that's the positive friend sign. For women, vaginal discharge with chlamydia, you get a little bit of vaginal discharge. It's not like gonorrhea. Gonorrhea is more significant discharge, but you get dysuria, bleeding, you can get all that. Pain with intercourse, dyspareunia, salpingitis if the fallopian tubes are infected, but then pelvic inflammatory disease if it's really bad. So here's your pelvic inflammatory disease. All the regions within the sexual reproductive organs could get affected by PID, right? So you can get the uterus, the fallopian tubes, the ovaries, everything can get affected by PID. So it's really, really nasty stuff. And like I said, this is what you get. This is what can cause infertility in a woman. So that's one of the major complications. If the woman's not infertile, the damage can also increase the possibility of getting an ectopic pregnancy. Ectopic pregnancy means that the embryo embedded, instead of within the endometrial lining, it embedded within the fallopian tube. Ectopic pregnancy, unfortunately, it's an emergence. It's a high risk for peritonitis and rupture, so you have to abort the child, unfortunately, when you have an ectopic pregnancy. So it's like a non-viable type of pregnancy. Gonorrhea is the second most common type of bacterial infection for STIs, second to chlamydia. And it can be asymptomatic, but as the name implies, rhea means perfusion of, right? So like diarrhea means like a lot of watery feces. Rhinorrhea on your nose, runny nose, right? Gonorrhea means that you have a lot of fluid discharge, like purulent discharge. So it can be asymptomatic, but if it's symptomatic, you're going to see a lot of discharge coming out. Again, it can cause conjunctivitis in a baby when they're being born. And treatments, very similar to chlamydia. You could use like a Z-Pak, azithromycin. You can also use ceftriaxone. You diagnose this with PCR. So thick, purulent discharge from the penis is going to be one of the hallmarks for gonorrhea. For women, painful urination, right? They can get excessive vaginal discharge as well too. But Moving on. So PID, the biggest concern there is infertility as well as ectopic pregnancy. Let me continue moving on. A lot of this stuff is going to repeat because chlamydia and gonorrhea are going to be pretty similar in the sequelae and the effects for both men and women. And again, for men, they can also cause epididymitis. It can also cause prostatitis if it affects the prostate gland. And that's it for chlamydia and gonorrhea. Any questions on that? Okay, cool. So here's just one slide I put in here for herpes because herpes virus is another very common STI. There's herpes simplex 1 and herpes simplex 2. 1, generally speaking, is what's going on with this guy over here. Your cold sores you get on the face. That's HSV1. HSV1 can also affect the genitals as well. But generally speaking, HSV2 is for the genitals, right? They can also be interswapped. You can get 2 on the face, or you can get 1 in the genitals. So, but generally speaking, 1 is on the face, 2 is on the genitals. And once you get it, you have it for life. You're not going to get rid of it. So there's no cure for it. You can treat it symptomatically. Basically, what the virus does, it hangs out in like the dorsal root ganglia, and then you have these eruptions that take place, right? You have these like reoccurrent episodes. And you can take these drugs, acyclovir, fancyclovir, janacyclovir, or valacyclovir. All the cyclovir drugs, antivirals, they're pretty good. Acyclovir has very few side effects, so it's actually a pretty safe drug to take. Here's a good chart that basically talks about the popularity of each of these STIs. So HPV is by far the most popular. HSV is going to be the second. Trichomonas, trichomoniasis, Trichomonas vaginalis. This is not a bacteria or a virus. This is a protozoa. So it's got a little tiny flagella and it swims. So that's Trichomonas. Chlamydia, bacteria, right? So this is the most common bacteria. Gonorrhea, number 2. Syphilis is pretty low on the list, but again, also a bacteria. Remember we talked about HBV, right? HBV, hepatitis B virus. It's sort of considered a sexually transmitted disease. You can get it in other ways too, but it's kind of an STI a little bit. So here's more on your PID. So PID can affect every single structure, right? It can affect the egg, the ovaries, so ophiritis, the Salpinges, which is involving like the fallopian tube, the infundibulum, cervix, vagina. All those things can be affected by PID. How do you diagnose it? You can do a pelvic exam. So you go in and you see if there's any cervical motion tenderness. So if you try to manipulate the cervix at all and it causes pain, that's cervical motion tenderness. You could see tenderness of the uterus as well. And adnexa. Adnexa is like all the supporting structures. So it could be like the suspensory ligaments, it could be the ovaries, it could be the fallopian tube. So if you palpate on the right and left lower quadrants and you feel pain, that's adnexal tenderness. Leukocytosis, because it's bacterial, right? So you're going to see white blood cells. I don't care about CRP. What's the complications? Again, ectopic pregnancy and infertility. So here's a uterus that's being affected. Look how absolutely red and inflamed that is. So that's a uterus with all this. Look at that. The Salpinges were all affected. That's all the fallopian tube, the infundibulum, all of that got affected. So that's all PID, pelvic inflammatory disease. And this is what happens with poor little kids that get born. If the mom has a STI, either chlamydia or gonorrhea, they get ophthalmia neonatorum. This is bacterial conjunctivitis, so they get really nasty purulent discharge, right? So their eyes are just like kind of just shut, right? And this stuff dries up, right? And it makes it really hard for the individual to open up their eyes. If left untreated, it can cause blindness, so pretty nasty. And when I said gentamicin, I meant erythromycin. So you can treat this with erythromycin. Back in the day, however, silver nitrate drops. They would put little silver nitrate drops on the patient's eyes, on the kid's eyes when they were born. We don't do that anymore. Now it's just erythromycin. All right. Any questions on STIs? Okay, let's move on a little bit now. So let's get into cervical cancer. I'm not going to test you guys on this, but again, HPV, major causes, right? These are the different serotypes, 16, 18, And then there's a bunch of other ones as well. But 16 and 18 are the most common. Multiple sexual partners, right? That's how you get these STIs like HPV. So, oh, and by the way, do condoms and barrier contraceptives protect against HPV? Yeah, they do not protect against HPV. So if your partner has HPV and you're sexually active, you're going to get HPV too, okay? So condoms do not help with that. Poor diet, long-term use of contraceptives can cause cancer. Smoking in general can increase your risk of all sorts of cancers, right? So that could be one thing. What types do you get? You get squamous cells, the most common, and adenocarcinoma is going to be the second most common. It's often going to be asymptomatic. You don't even know you have it. Sometimes you get vaginal discharge and a little bit of bleeding, especially post-coital. And here's the progression. You get dysplasia, you get the carcinoma in situ, and invasive carcinoma. And again, most common cause is HPV. So like I said, I'm not going to test you guys on cervical cancer, but I would be remiss to skip that altogether because it's a very common thing that you see out there in the field. That's why, you know, it's good for women to get screenings, right? Get your pap smear done, right? So you can help to. Early diagnostics are the best, right? Diagnose this nice and early so you can treat it easier. Now let's talk a little bit about hormones. So androgens, the major ones are going to be DHEA, dihydroepiandrosterone. I'm going to say DHEA from now on. Androstenedione is another one. The ovaries are going to produce estrogens. Estradiol is the most common. There's 3 types of estrogens, but estradiol is going to be the most common, as well as progesterone then from the ovaries. And then testes are what produce testosterone and dihydrotestosterone, which is DHT. So here's all the pathways for like hormone production. Don't worry about all this stuff. I'm not going to test you on all the like the enzymes and intermediaries and all that stuff. I'm not going to test you on that. But it's good though to know what's going on with testosterone. Testosterone can get aromatized with aromatase and it can turn into estradiol. Testosterone also, when it comes in contact with 5-alpha reductase, it can turn into dihydrotestosterone, DHT. These things can enlarge the prostate. And so you can get prostatic hyperplasia. Benign prostatic hyperplasia you can see with all this happening with aromatase, 5-alpha reductase. Finasteride, a commonly used drug for BPH, that's what it does. It blocks 5-alpha reductase. So it's a 5-alpha reductase inhibitor. Finasteride can help to reduce benign prostatic hyperplasia. Aromatase is something that can also increase the risk of a man developing breasts. Gynecomastia, there's certain things that can increase aromatase activity. Alcoholism being one of them. So a person who's like a long-term alcoholic. Also, if they're obese, a lot of these things can also increase aromatase activity. So that's why a lot of alcoholics who are obese also develop some severe gynecomastia. Now, with BPH, with the prostate, it's benign, right? So it's enlargement of the cells, but it's going to be benign. So you get cell growth, and it's going to supersede the apoptosis. When you're born, the prostate's very small. As an adult, it turns into a walnut-sized structure. And BPH, guess what? Most of us dudes are eventually going to develop some varying degree of BPH. Yeah, it just happens. So not like a huge deal, but it can be pretty discomforting, especially if it starts affecting the urethra. Right? That's one of the biggest reasons why we have things like overflow incontinence. Right? Overflow incontinence, where you have a really hard time urinating, right? Because you're putting too much pressure on the urethra, so you get overflow incontinence. 50% of guys over 60 have it. When you're over 70, 90% of guys, right? So it's one of the most, it's one of the most common things that's going to affect a guy in their older age. Women don't get it, right? Women don't have prostates. So being an old dude, that's the risk factor for BPH. Pathophysiology, estradiol, also dihydrotestosterone, DHT, that all helps to increase the prostate. So aromatase activity, and 5-alpha reductase activity. All those things cause BPH. Signs and symptoms, you're going to be wanting to use the restroom a lot. So you're going to want to pee a lot, but you're not going to be able to pee much. So when you go use the restroom, you're going to be dribbling out a little bit. So you're going to have a higher frequency of urination or higher urgency to want to urinate, right? But the actual volume of urine is going to be very little. You also get nocturia at night, right? Weak stream, obviously. Gynecomastia because of the whole aromatase activity. Right? Aromatase converts testosterone into estradiol. And then you can see hematuria at some point. You can see kidney infections, hydronephrosis. Hydronephrosis is where the ureters start to dilate even more, because if you can't pee, all the urine backs up towards the kidneys, and so the ureters can start to dilate. How do you test for this? You do a digital rectal exam, also known as a DRE, not to be confused with Dr. Dre. So a DRE is a digital rectal exam. So you put your glove on and you go in there and you try to feel around for the prostate. You're checking for the most part for prostate cancer. That's one of the major indications for a DRE. I forget what age it is. I think it's 45 years of age is the recommendation. They changed the recommendations not long ago. I think it used to be a little bit higher than that, but I think 45 years of age is now when it's recommended for a guy to get a DRE. Some people can go earlier if they have like risk factors, right? You can get a DRE a little bit earlier in life. So DRE is going to be the main thing that you're looking for. If it's rough, that means it might be cancer. But if it's smooth and it's enlarged, that's BPH. You can also do a blood test. So that's the prostate-specific antigen. You can track this over the course of a person's life too. As guys get older, you can track their PSA levels. You could also do an ultrasound, or if you're suspecting cancer, you could do a biopsy. How do you treat it? Meds. Finasteride is going to be one of the major drugs. So that's the 5-alpha reductase inhibitor. If it's really bad, you can do a transurethral resection. Does that procedure kind of suck? It does kind of suck. I think I was talking to you guys about my family friend. He's like in his 70s. He had that done, and now he has to wear a diaper because he pees all the time. So medicine is a double-edged sword sometimes. You treat one thing, but now you have to treat something else in return. So here's gynecomastia, where you have excessive amount of breast tissue. Where are we at here? Wow, we've made significant headway. I didn't realize we were going to make this far. That's awesome. Gynecomastia, that's where you have overdevelopment of breasts in men. Generally speaking, it could be idiopathic. It could be due to other disorders as well. Drugs can cause this. Certain cancers can cause this too. Does a guy with gynecomastia have increased risk of breast cancer? We've already established that. Yes, you can see increased cancer with these individuals. What's the underlying cause? Estrogen, testosterone. So the ratios get kind of messed up. And so if you start aromatizing your androgens, you start getting more estradiol. Okay, so if you have too much estradiol, that's going to increase your risk of developing gynecomastia. Aromatase activity is increased by increasing age, obesity, insulin, and alcohol consumption. So yeah, there's that. So if you're overweight, if you're an old, overweight guy who likes to drink a lot of booze, you're going to get gynecomastia, or at least you're going to have a higher risk of developing gynecomastia. Now, prostate, this is normal prostate, right? You shouldn't have any sort of issue. Once the prostate starts getting enlarged, that's your BPH, benign prostatic hyperplasia. If it feels lumpy at all when you're doing a DRE on a patient, that could indicate prostate cancer. And so that is much more concerning. With prostate cancer, the risk goes up as you get older, right? The older you are, the more higher risk you are to develop prostate cancer. It is pretty freaking common. It's very common. So if you're in your 40s and 50s, 1 in 38 individuals are going to develop it. If you're in your 60s, 1 in 15. Family history is going to be significant, as well as diet and lifestyle. It's going to be more seen in African American demographics. And it is slow growing. It can be asymptomatic. It can look a lot like BPH. And sometimes if it's bad enough, you can start getting urine, blood in the urine, so hematuria. And then this chart over here talks about metastasis. So all the different areas in the body that you can get metastasis of prostate cancer. So it can metastasize to the bones, right? That's going to be one of the major sites of metastasis. So you get bone metastasis. You can get also metastasis to the lungs. Lymph nodes are going to be some of the first areas where you see metastasis. So this can spread to various parts of the body. All right. Now let's move beyond prostate and let's talk about the testes. So there's three major testicular pathologies that you guys are going to be responsible for. Okay, one is the bag of worms. That's the varicocele. So that means you have some sort of like obstruction of drainage of the veins in the testes, specifically the pampiform plexus. So if you feel the patient's scrotum and it feels like a bag of worms, that is likely a varicocele. Hydrocele is just water, right? So you're getting watery type fluid accumulation within the tunica vaginalis. You take your pen light. I know more people are using their cell phones nowadays to like do like the pupillary reflex and stuff. I don't think I would recommend taking your cell phone light and looking at someone's scrotum. I would recommend using a pen light instead when you do this. So you can take a pen light and you can see right through it. So if you can see right through it, it's trans-illuminated. That's very likely a hydrocele. And then a spermatocele is where you have, in the epididymis, you have an epididymal cyst. And you get a lot of the seminal type of fluids involved in that. Varicoceles, if it's really big, you might get symptoms. Otherwise, it's asymptomatic, very slow. It could cause infertility. You could treat that with surgery. Hydrocele, usually due to trauma or inflammation. It could be one of the testes or both of the testes, so unilateral versus bilateral. The bigger it is, the more painful it is. You can see this in young kids that are born, so newborns can get this, and it usually resolves on its own. Then a spermatocele, that's in your epididymis, epididymal cyst. That's usually benign and painless. So that's what these look like. You got a bag of worms, varicocele, fluid, right? That's going to be hydrocele, and then spermatoceles where you have your epididymis might have like a little lump. So epididymitis. We already kind of covered a little bit of this when we talked about gonorrhea and chlamydia. So this is what happens to guys when they have STIs. You can also get other bacteria, again, like E. coli, enterobacteria. Pain that is worse withstanding, right, because of gravity. And again, positive friend sign. You elevate the testes, and that can help reduce the pain. Orchitis, so the orchids. When you have orchitis, that's when you have inflammation of either one or both testes. Causes bacterial or mumps. If you have mumps, that can increase your risk of developing orchitis. You can develop epididymitis as a consequence. And here are, these are risk factors. Epididymitis, being sexually active because it could be bacterial, and benign prostatic hyperplasia. Symptoms. You'll be febrile, so you'll have a high fever, leukocytosis. Whenever anything affects the testes in general, that can really cause some like nausea. So like nausea and vomiting. Any of the guys in here that ever had an injury to the nether regions know this full well. There's like skateboard videos that I used to watch when I was a kid, like especially like Zero and like some really fun skateboard videos. And they would have like these montages of these professional skateboarders just like it's like racking themselves on a handrail and then just like immediately just barfing because they'll just get super nauseous and just start vomiting everywhere. So nausea and vomiting you're going to see with orchitis as well. Pain is going to be worse with any sort of contact, so you're not going to get a friend sign. So if you touch their testes, they're not going to be your friend. So you get a negative friend sign. Edema, tenderness, and the scrotum might look shiny and inflamed. These are all the complications: hydrocele, abscesses, a blood clot, infarction, infertility, sterility, etc. How do you diagnose it? You check to see if you have an STI that might have caused it. You can do urinalysis. And testicular torsion, which we're going to talk about in a second. So you want to rule out a testicular torsion, because testicular torsion is probably one of the scarier ones of all of these, because if it's over 6 hours, you have to cut the testicle off. So testicular torsion is very dangerous because you're basically siphoning off the blood supply to the testes. Again, negative friend sign. Antibiotics if it's bacterial, anti-inflammatories if it's like mumps. So here is testicular torsion. Testicular torsion is where the testy gets all kind of tangled up, and it's going to cause ischemia. So if the spermatocord is twisted up, it's ischemia. You need to go get this test fixed immediately. It is a medical emergency. Why does this happen? It could be spontaneous, or it could also be due to like injury, like trauma in sports. Severe unilateral scrotal pain, nausea, vomiting, swelling, high riding testicle, because it gets all twisted up and it just gets kind of like, you'll see it a little bit elevated. If the testes are also really hard, that's another concern. So look at this testy over here. That looks like it's necrotic. I think that this person probably had to lose their testy. So if it's black like that, you might have to get that removed. So surgical emergency within 6 hours. If it's beyond 6 hours, you will probably have to remove the affected testy. So there's a little test you can do. It's called a twist score. We'll talk about that in a second. The cremasteric reflex. So again, put your glove on, and then you kind of gently rub the inner thigh. And if you see the testy moving up, that's a cremasteric reflex. Okay, so I think it's the pudendal nerve. If I remember correctly, you're stimulating the pudendal nerve, and that helps to elevate the scrotum. So if that doesn't happen, that might indicate that you have testicular torsion. Surgery, again, you want to untwist this. If it's over 6 hours, an orchiectomy. That's what we call it when you remove a testy surgically. So here's your twist score. If it's less than 2, that means it's no testicular torsion. If it's 3 to 4, you want to check to see what's going on there. You might want to do an ultrasound. If it's 5 to 6, you definitely want to do surgery. So this is the testicular torsion test. So if you see the swelling, that's a 2. Hardening of the testicle, 2. Nausea and vomiting, 1. If the cremasteric reflex, which is this, right, you just gently kind of touch the inner thigh, then that's 1. And then high riding testy, that's also 1. So if it's anywhere between 5 to 6, that's you want to go into surgical, want to take that patient to surgery right away. Yes? A what?
An open book maneuver.
What's that? An open book maneuver?
That, and then they open it like this, and it resolves a lot.
They take what?
Scrotum.
They take the scrotum and they...
They grab it and then they open it like this.
I've never even heard of that. I've never even heard of that.
That's what most of the time will do that. If they're under like a certain age, like if they're younger.
Okay. So it's called an open book what?
Open book maneuver.
Open book maneuver. Oh, that's interesting. I never heard of that before. I'll have to look into that. Yeah. Send me a message about that. I'll start including that in my future presentations. So any questions on testicular torsion? All right, let's talk about testicular cancer. Gosh, we only have a few more minutes left. So let's talk about testicular cancer. It's not the most common, but it does happen. It's 1% of all the tumors that affect guys. The biggest risk factor is going to be undescended testes. If a person is born and their testes are still within their abdomen, right, and they don't descend properly, you sometimes have to do an oophorectomy on that too. You might have to, an orchiectomy to remove the testes, because that can increase their risk of cancer. Other things, family history, HIV, AIDS, those are all things. Klinefelter. What do you see in terms of symptoms? You might see an abnormal lump or mass. You might feel some pain. The person, if it's affecting their hormones, could get gynecomastia, so beta-HCG tumors could affect that. How do you diagnose it? You could do different type of tumor markers, ultrasound, CT scan. Treatment, It's pretty successful treatments. You just do, testicular removal, so orchiectomy. If it metastasized beyond the testes, then that could require radiation therapy. Now let's talk about the foreskin, also known as the prepuce. The prepuce is the fancy term for foreskin. If you have phimosis, that's where you can't retract the prepuce, right? So the glands of the penis is not able to protrude through, right? So the prepuce is super constricted. Paraphimosis is where the prepuce isn't able to move over the glands. And so it's going to be basically contracted, right? And so or retracted, and it can't move over the glands. Usually that happens in younger and older individuals. It is very painful. And usually you want to do a surgical circumcision to be able to treat that. I'm not going to play the video, but if you want to watch that on your own time, feel free to do so. Epispadias versus hypospadias is effectively a misplaced urethra. The urethra is either above or below the penis on the shaft, right? So if it's above, that's going to be epispadias. If it's below, that is called hypospadias. And this is something that happens relatively frequently. So 1 out of 125 individuals are going to have hypospadias. 1 over 117,000 are going to have epispadias. So hypospadias is by far the most common of the two. And this can happen anywhere. This can happen anywhere between the glands and the perineum. The perineum is the area between the scrotum and the anus. So you can get hypospadias, especially around the perineum. And then surgery, you want to do surgery, and you don't want to circumcise this kid if it's like a newborn baby. You don't want to do a circumcision yet. You want to correct the epispadias or hypospadias first. Yes?
Did you hear the rumor that Hitler had hypospadias?
Huh?
Did you hear the rumor that Hitler had hypospadias?
Hitler had hypospadias?
Yeah, I've heard that like a few times.
I think Hitler had a lot of issues. Syphilis, hypospadias, psychopath, all those things. Anyways, what is this? Is this hypospadias or epispadias? It's going to be from the bottom, right? Hypospadias. Okay, let's move on because we got a couple more things I want to talk about before we leave. What time is it? 42. We got 2 more minutes. All right, priapism. If you have an erection that lasts for more than 4 hours, that is priapism. That is a surgical emergency. You want to drain that erection, right? Because if blood remains trapped within the corpus cavernosum, that can start to coagulate and become a thrombus, and that can actually cause penile necrosis. So you have to drain the penis. It can be idiopathic, but this is one of the most common causes. If you're partying and you decide that you want to take Viagra with cocaine, that is a really good cocktail to cause priapism. So, yeah. Ultrasound, CBC, and then penile drainage. I am not going to play this video, but you can watch that on your own time. If you want to see a penis getting drained, that's the video for you. Peyronie disease, this is where the penis is bent. So bent nail syndrome. You get fibrous plaques. It happens in middle-aged men sometimes. Especially happens when an individual has a penile fracture. We're not going to talk about penile fractures, but you get this, they call it the eggplant presentation of a penile fracture. Blood basically just engorges in the penis. And as it heals, you get fibrotic tissues. And after that, you get everything bent from here on out. And you can do surgery for this. This is the surgical procedure you could do. Partial plaque excision and grafting with collagen fleece in Peyronie disease. Here's an article if you want to read up on that in more detail. And before you guys leave, log into this. I only made one question, but I want you guys, I'm going to make more questions over the weekend. So for now, just quickly log into it so you can have access to this over the weekend. So do this really quick before you guys leave. And once you log in, I'll hit start, and then you don't have to answer the question. You can get out of here. Yes.
Over the summer, I assisted with the surgery, which there was a mass in a dog's abdomen, and the dog was neutered supposedly because we did the test, and he didn't have testicles, and the doctor got in there and she found a testicle, like
No
a normal
kidding.
sized one, and then the big, like, it was like a chihuahua sized dog.
Yeah.
And the second testicle was, I kid you, like this big.
Oh my goodness gracious.
And she was like, well, I guess we just did a neuter. But it started as like an exploratory.
Wow, that's insane.
Because he never, like,
They never descended, so it's undescended testes. That's incredible. All right, did everybody log in? All right, if everybody logged in, then you guys can go. Have a great weekend. That's it. That's the last lecture. So on Wednesday, we'll do a big comprehensive review of everything. I'll do like a quizzes review session for you guys. And that's basically it. So awesome. Have a good weekend.